Lero navukiye mkwai nalifye bwino so ichungulo naishile mvwafye mutu kachuwaisa ule kalipa makoko pamolu sofe pafitye nokufite finalele mutu ule kalipa fya makanaya pwa shanu nipo mjuli wonse na yefe mayonga bwachanga apa kliniki mbone finalavuka finavukile fitafile chinje finambili okuluka ndeluka naimine nashita nebukwa chinde apa kliniki. Finafikile pa kliniki palya fiba ndichile mu office bamukunjipusha nishule mfwana balondola nde mfo mutwe mala mbili wonse ule kalipa fiba ndembele buku fiba ile tikalipa kupimi palya. Fiba mpimine fiba nsangile na malaria fiba ndibelati toakupera omuti kosi wambye okunwa fibampere kosi bampera neshite yakunwa.
Malaria is a parasitic disease that is transmitted between humans through the bite of the female Anopheles mosquito. According to the World Health Organization World Report of 2019, Africa accounts for about 93% of malaria cases worldwide. According to the report, the incidence rate of malaria declined globally between 2010 and 2018 from 71 to 57 cases per 1,000 population at risk. However, from 2014 to 2018, many parts of Africa and Zambia experienced stagnation. This necessitated a renewed effort to control and later eliminate malaria. To accelerate progress towards malaria elimination, the government of the Republic of Zambia, through its Ministry of Health and the National Malaria Elimination Center, is pressing on with its ambitious National Malaria Elimination Strategy with the goal of eliminating malaria in local communities.
Malaria remains to be a grave public health threat, claiming thousands of lives amongst our pregnant women and under 5 children. Further, malaria accounts for a significant proportion of reasons why our people abscond from work, reducing productivity. Malaria remains a public health threat. The Zambian government, under the stewardship of His Excellency President Edgar Chagwa Lungu, recognized the need to eliminate malaria, to enhance productivity, to enhance wellness. It is for this reason that malaria elimination is recognized as one of the key legacy goals. To state our intentions clearly, the President launched the National Malaria Elimination Program, a clear shift from malaria control to malaria elimination. To this effect, the National Malaria Elimination Program was mooted. The program was changed from one to control malaria to one to eliminate malaria.
Since 2015, Zambia, with support from the United States Presidential Malaria Initiatives, funding to PATH, are implementing a government-led and government-owned countrywide program to scale up proven malaria interventions.
The U.S. President's Malaria Initiative was created under President George W. Bush in 2005, and we're fortunate that the program has been supported by all the presidents since, so President Obama and President Trump. In fact, the program keeps expanding under each president. It was begun as a way to really channel some serious resources from the American people through the initiative to countries, mostly in Africa. We are in 29 countries, almost all are in Africa. And the idea is to take proven interventions, such as insecticide-treated mosquito nets, such as indoor residual spraying, improved diagnosis and treatment, surveillance, all the critical pieces of malaria control and elimination, and to take these proven tools and scale them up seriously for the masses. Because malaria affects, huge populations, and you need these interventions to get out on a large scale. So the US government is helping to bring the necessary resources, the funding, the technical assistance to make this happen.
Zambia is a wonderful example of country ownership and country leadership in the fight against malaria. By partnering with organizations such as PMI and their initiatives like Program for Advancement of Malaria Outcomes, PAMO, Zambia is beginning to record reductions in malaria cases in a number of areas.
The burden of malaria in Zambia actually is not uniform. We have parts of the country where we have very low malaria burden in the southern part, and actually in Lusaka here where we are almost in what we call pre-elimination, while in the northern half of the country we have a higher burden. As a country as a whole, we are at a burden of 312 per thousand as at 2018.
So this project started in 2015. It was put up by the US government, and PATH won that project. And it's a 5-year project, which is covering 4 provinces, the districts in those provinces, but also supporting the National Malaria Elimination Center. It looks at different interventions, different objectives. The first one is what are the proven interventions that we can be able to do? So here we're looking at insecticide-treated nets. We're looking at case management, improving diagnosis of malaria, improving how the data is being managed. Then another part looks at the staff, equipping the staff in the health facilities, but also the managers to manage this project. So if you are going to reduce malaria, you need to look at the managers. Are the managers equipped? Do they know how to manage? Are they planning? Do they have the resources? Do they assign resources? Do they use data to assign to resources? Then another component it looked at is how is the data? If we're going to eliminate malaria, you need to know that the burden is coming down. So it addresses the quality of data that is being generated. So this project was created in that way, and it was put out, and that is the one we're implementing.
Zambia was an early adopter of the insecticide-treated nets strategy in 2001 and policy for mass distribution with insecticide-treated nets in 2005. Since then, the country has implemented mass distribution supplemented with routine delivery through antenatal care under 5 clinics in health facilities as well as schools.
The insecticide-treated net distribution campaign in Luapula in 2017, the country was implementing a campaign across all provinces, and PAMO really took on Luapula. And I think that the progress of that campaign was exemplary. Appropriate enumeration of households, very strong distribution approach, working with local headmen and other traditional leaders, making sure all the logistics were there, coordinating with other partners to get insecticide-treated nets in the hands of the population. And I think when a survey was done a year later, it really showed that Luapula had very high, historically high coverage rates of insecticide-treated mosquito nets. And I think PAMO was instrumental in making that happen.
To control and eliminate malaria, it is very important that in every season of the year, people sleep under an ITN every night, all year round. PAMO works with the Ministry of Health to educate the community on the proper use of ITNs. Working with community members including headmen, religious leaders, and other community volunteers, PAMO supports implementation of health education to explain the importance of sleeping under an ITN. Healthcare providers and other community volunteers also demonstrate how to use a net and how to take care of it in order to effectively protect members of the household from malaria. Access to health care is necessary in prevention and treatment of malaria. In Zambia, there is just a single doctor for every 12,000 people. The shortage of healthcare workers, however, could be much worse in some rural areas, making it a real challenge for many rural communities to access healthcare service providers for their most pressing needs. To increase access to healthcare services, the Zambian government is committed to bring healthcare as close to the households as possible. Enter the community health workers rollout.
To date, we've trained over 2,500 community health workers in managing malaria. So they are able to test. When a person has malaria, they can go to the community health worker, test the client, and when they are found to be positive, they are given treatment.
The Community Health Workers Program is a national program supported by various partners and implemented across the country. The partners include the Global Fund, the Gates Foundation through Paths Malaria Control and Elimination Partnership in Africa, the Churches Health Association of Zambia, Eastdale Flowers Cross-Border Malaria Initiative, the Rotary Club, and many others. PAMO is supporting the Ministry of Health to roll out the Community Health Workers Program in 4 provinces: Eastern, Luapula, Muchinga, and Northern. A community health worker is trained to provide the most essential life-saving interventions, such as emergency frontline care, and can help save children's lives from many, if not most, of the major preventable child mortality cases like diarrhea, pneumonia, and malaria. Community health workers are trained to test and treat community members for malaria and also equip families with the knowledge and skills to prevent disease. They promote good nutrition, sanitation, and hygiene and link families to essential services. Community health workers are nominated by their own communities to provide health care at household level. After undergoing a training using the Ministry of Health curriculum, these individuals receive a modest set of enablers and incentives, which include bicycles, talk time, a t-shirt, cap, and apron. However, these volunteers receive no ongoing monetary compensation for their work. In their spare time, community health workers grow crops or keep livestock as a source of income. Even though there are only 3 distinct program phases in the fight against malaria, that is, control, elimination, and prevention of reintroduction, the Global Malaria Program, GMP, classification also includes a transition phase of pre-elimination. Pre-elimination consists of the period of reorientation of malaria control programs between the sustained control and elimination stages, when coverage with good quality laboratory and clinical services, reporting, and surveillance are reinforced. PAMO is currently implementing this phase of pre-elimination in Chadiza, Katete, and Sinda districts of the Eastern Province of Zambia.
In the pre-elimination program, the focus is in supporting moving malaria incidence to the level where we are ready to completely eliminate. And so the interventions are concentrated. There is saturation of things like ICCM, community case management, so that we bring the health services as close to the family as possible, so that the community people have the liberty and the freedom to go to the homes of their very own people within the community.
In pre-elimination districts where malaria incidence is low, PAMO supports government to implement its policy of active cases detection of malaria at household level. This involves community health workers following up on a few people that tested positive for malaria to test and treat members of their household and neighbors in order to clear malaria parasites. During their work, community health workers share information with community members on how to prevent malaria. Through interactions with community health workers, communities receive accurate information and can then embrace proven techniques, innovative new strategies, and can take a giant step towards a malaria-free future.
Sono isenchito yatu mwene timasebenzera mu community makamaka kuthandizira baja amene amapezeka na nthenda ya malungu ali na zisanzo za nthenda ya malungu ndi amene timasebenzerapo. Isenchito yathu ma positive aya amene timakonkha yena amachokera mu community mwene tinkhala vena bachokera ku chipatala. Mwachisanzo ngati munthu mu community wapezeka positive na malaria positive, timapita pa nyumba nopima babanja wonse ndiponso na manyumba yoyandikizana nayo 140 meters. Sono ku chipatala kuja timaona ma register ija pa chipatala kuona kuti ngati kuliko munthu amene apezeka positive. Sono ngati ndine ni lusenzera pa chipatala napezako positive ngati achokera ku catchment area isali yanga nizatumira munthu amene ali ku catchment area yake kuti akapime ku nyumba kumuzi kuja kwena achokera yeve.
PAMO supports us in proven interventions to eliminate malaria. So there are various activities that we as a health sector in Sinda we may not have been able to do on our own. But in partnership with PAMO, we are grateful that most of these activities have been done, and so far, so good.
From the time these community-based volunteers were trained in case management of malaria, we've seen a lot of changes as the facility, owing to the fact that we used to receive a huge number of people. As you can see, this area is highly populated, and there was a lot of work to be done here. But from the time they were trained, we've taken a service to their doorstep, owing to the fact that they are able to access these services in good time and within their reach. Okay. And the client flow here has reduced.
Besides training community health workers in managing malaria at community level, PAMO also supports the Ministry of Health to strengthen healthcare workers' skills in managing malaria at health facility level. This includes training them in the proper use of rapid diagnostic tests and microscopes for malaria diagnosis.
So you may wish to know that for the diagnosis of malaria, you can use a rapid diagnostic test that we call a malaria RDT.
If someone has a fever and the RDT maybe comes out negative, the next step you can take is to check if there's other infecting species of malaria can be infecting that person, so that we rule out malaria completely and look into other venues of diagnosis. And the other reason we do the blood slide is because we have to quantify. Upon admission, like the patient we had today, came in the morning, they had an RDT done and it was positive. So we quantify the malaria, though it's a low parasitemia, but we still have to quantify. And then after their treatment, we'll still have to do another blood slide to see if the parasite is completely cleared. Because some people may not respond, or some people may not take their medication fully, so the parasite will still remain and we can have reinfection that takes place. So to ensure that all the patients coming through are fully treated, we have to quantify the malaria, the parasitemia upon admission and upon the patient being discharged from the hospital.
As each country battles malaria, they need to know when and where the battle is being won and where significant challenges remain. Surveillance of the disease can provide those answers. And when the country or a district within the country has been able to reduce an area's parasite prevalence to a handful of cases and is on the road to elimination, accurate rapid surveillance becomes even more important because it allows malaria teams to focus special attention and direct follow-up to a few remaining cases.
So we really appreciate what PAMO has done. So there's step D or surveillance programs going on well, because also it didn't end up at just training. We continued with supervision, monitoring, data collection, data quality monitoring, data quality audits, data quality reviews, so that we ensure that if we are talking about the incidence, we're talking about the right figures.
Based on the government's national malaria communication strategy, PAMO is using the applied behavioral change communications approach. This involves community-based interpersonal communication methods, mass media, performance art, and advocacy by local leaders. The aim is to educate community members on the proper and consistent use of malaria interventions to help them understand why they are so vital in preventing malaria and to influence the community members accept, adopt, and consistently use all malaria prevention interventions. Radio, television, and public announcements can be an effective means of reaching large numbers of people. To reach targeted populations with key malaria messages, PAMO uses interpersonal communication. This is a powerful method to teach, answer questions, and reduce unwarranted concerns.
This organization is working in partnership with PATH. What we are doing as an organization, we are working with various categories of the community members, and to champion the community engagement, we've trained the change champions, which we are calling community change champions. These are the people that we are working through to reach out the masses in the communities. And the key agenda that we have is to contribute to the elimination of malaria.
However, in the era of COVID-19, PAMO has modified these interventions to ensure social distancing to limit the transmission of COVID-19.
naine wenale bonfya kwa mosquito ne chukunyungira ko bunga mbali ntubaishide mukutusambilisha nalisa zangu kuti mwali bo bwafya mukuba bonfya mosquito ne chukunyungira ko efya kuti bantu kula bo mucho babikako wa kuchingirira malaria mba uli omuchinga cha kuti twatende kukula bonfya kucha mukunyunga kuti waleto wafya kumibili Yesu.
Some have just started, just coming to the realization that for sure what they have been doing in the past was wrong. It is not helping themselves, not helping their families, and not helping the community at large. Because such practices, it was just putting them at risk of contracting malaria. And in the process, you know, the village mentality and beliefs, they wouldn't even believe that a child died from malaria. They will bring in all sorts of misconceptions, myths, you know, he was bewitched, it's witchcraft. So all things have started now hammering and removing them from people's minds so that we can move at the same pace. So the picture is changing also, something which we are very happy as a project.
Aho kwena mwandinire weya tusansamusha. Pantu ile weya tuangukirako. Akale kwale bo muntu ngana ulwale fyofine limonga nawe ya kliniki kuchipatala. Limbi kuti ulwali obushiku kano akasuba limbi pakuti bese bakumoneko inshita ya poseka. Ero bambi balefuira na pali apene fe limbi pachipuno muntu afu. Nomba chali becha tuangukirako. Pantu wala tubaka bwangu. Palapa kwe bati tutole ntamfu yako ya kuchipatala nangu ku kliniki. Bena bwangu nga bakusosera basanga na ukwata obulwere bwa malaria yo ineshita bakupera omuti watampa n'okunwa nga bwaisa kyolukyelo kwisa kupempulo kwisa muna mushuwike shani emukwaye
ine kwanga no yamikira mwamene wa health imene tilugwirira nawo ntchito ine nithokoze kwambiri kuti asabwerera kumbuyo chifukwa ntchito kuno kwathu zinthu sizinalitere zinali zinthu zoyipa kwambiri kwakuti ngozi tinalukhala matenda komanso maimfa yosaziwika bwino vana kumafa kamba kankhani za malaria pomwe sisi timakumbukira icho timawambiri mabanja pamathamangira kumang'anga mwina ng'ange kumasitima zoto chichitika nchani. So lomba wa health potithandiza kwambiri notiunikira kuti tizive kuti matenda yabwera tere. So ise kuno lomba taupeza umoyo wabwino na kuti chikhulupiriro chathu kumang'anga lomba vanthu mafamili ambiri yachokeratu lomba valuganiza kuti kansi munthu ukadwala ndiye kuti suzisamalira pa nkhani za malaria.
If we can saturate more and more areas with the package of effective tools, we'll do well. And Zambia has a stratified approach where it's not one size fits all. Depending on where you are, where your epidemiologic level is, there's a set of interventions that should really be prioritized. And it's a good plan. So if you're in Luapula, all right, we're not bringing in focal IRS. We're doing mass IRS. If you're in a high burden area, you really need to emphasize diagnosing and treating every case, and not so much going out and looking for asymptomatic people. However, when you're down in the low levels, you do need to go find those asymptomatic people. Do a test and treat approach through the community surveillance, for example. So I think if we can stick to that plan and really make sure enough resources are available at every level.
We're not yet happy at the rate at which we are moving. That is why we feel that we know what works. We know that the ITNs work. We know that spraying the houses work. We know that getting people treated on time works. But we also know that in order for us to get that impact, we have to have all these interventions at the 100% coverage throughout the country. And then we also know that to end malaria, it cannot only be at the health facility level, but it has to be at the community level. We need the input of the traditional leaders, the church leaders, the other religious leaders. We cannot do it on our own because we need everyone to take it as a personal thing.
Our objective is basically to reduce the prevalence of malaria to as we say, to elimination, for us to be able to say that we are fighting the battle.
PAMO has worked with us in capacity building, human capital enhancement, to ensure that we have hands to do the indoor residue spraying and to do the case management. The US government, through its various programs, has worked with the Zambian government to push the malaria elimination agenda. So we recognize PAMO as a strategic ally in malaria elimination. And let me use this opportunity on behalf of His Excellency President Edgar Chagolungu and the government to express unfettered gratitude to PAMO for the partnership, for the solidarity, for the unity of purpose, for the common aspiration to eliminate malaria.
We want a malaria-free Zambia. Chelenge? Yes, we can.